So Professor Paula Salko, thank you so much for participating in this session. I'm just going to introduce you, that you're a medical sociologist focusing on health, mental health and technologies, from social media and online genetic tests to cardiovascular risk assessment and urinary dipsticks. Based in Loughborough University, and the presentation is based on, this presentation will be based on a qualitative study on healthcare professionals and older adults' experiences of diagnosing UTIs in hospitals. Thank you very much indeed.
Okay, so very interesting talks, a bit very well together. Can you hear me okay? Yeah, okay. So basically, I will be talking about a study that we conducted a few years ago about diagnosing UTIs in older adults in hospitals. And I will be continuing the story so far. Matt, could you have the next slide? So diagnosing older adults is a little bit different from what Elena talked about in relation to patients that are under the age of 65. Older adults are a bit more complicated, perhaps, or at least differently complicated. It's often understood that a lot of older adults have bacteria in urine, so-called asymptomatic bacteriuria, which doesn't constitute a proper UTI. So you find E. coli, etc., and it's not considered to be a UTI. And the clinical guidelines say that basically UTIs should be diagnosed primarily based on symptoms and signs, and not via urinary dipsticks that would detect, white cells, and not also using bacterial cultures, so that should not be a diagnostic tool, but we should use bacterial cultures to confirm diagnosis and, figure out which antibiotic to use. And then there are these mentions that some symptoms, such as pain or dysuria, is more specific and more likely to be a proper UTI, whereas some signs that are listed in the guidelines that are non-specific, such as confusion, are not particularly good because, older adults can be confused for a variety of reasons. And when I started this study, and I hope these figures have vastly improved, but at least to some, it was estimated that between a third and 40% of diagnoses of UTIs in older adults in hospitals in different countries were overdiagnoses, that they were not considered to be a true UTI. And for AMR, this was obviously is a big problem. Could I have the next slide? So we basically set out to explore this because some microbiologists said that this is a huge problem, and let's go and figure out what's going on. And so I was dispatched to interview a whole bunch of healthcare professionals and older adult patients. And when I started the interviews, I found it very confusing, and I'm not a newbie. I've done a lot of interviews in my time, but I found it very confusing that all the nurses and doctors that were telling me how they were diagnosing UTIs were not following the guidelines. And I kept calling the microbiologist and I said, well, what's going on? Are you sure, etc. And she said, yeah, this is exactly what's happening. And then I was kind of scratching my head and wondering what's happening here exactly, because, I thought it was unusual. And I ended up concluding, a bit resonating with what Annie just said, that the guidelines about UTI diagnosis in older adults kind of more or less diametrically is opposed to the modern diagnostic hierarchies in terms of the hierarchies of what is the best kind of evidence and what is not so good evidence. And I'm kind of giving a slew of names of sociologists and philosophers that have been discussing this issue. So usually in modern medicine, diagnostic tests are understood to provide the best, most objective evidence because they are able to illuminate the cause of disease that hides beneath the surface of the body. making it visible. So we can all of a sudden see the bacteria causing the disease. And this was kind of the big advance of modern medicine. Then the next best evidence is usually considered to be expert observation of signs of disease. So the healthcare professional looking at the patient, which is called the clinical gaze, and that is usually seen as the second most reliable form of evidence. And the third, not so good form of evidence, but still evidence, is patient subjective experiences of symptoms. And that is kind of the sort of modern hierarchy as sort of laid out by these scholars. And obviously, if we then go back to the UTI guidelines for diagnosing older adults, it kind of turns this upside down, because all of a sudden diagnostic tests are dubious. And the best form of evidence is this subjective experience experienced by the patients. Okay, so Matt, could we have a next slide? Okay, so this is just a kind of little visual that, kind of illustrates how cholera was kind of looked for causes of cholera everywhere, and was very ambiguous. And, there were all these stories about what causes it until bacteria was found. And that kind of was seen to kind of, provide clear evidence and, clear the ambiguity of diagnosis that we're talking about here. Next slide, please. So that study, so basically, I did this with our colleagues that will be in the last slide, and we explored processes that lead to overdiagnosis of UTIs in older adults in hospitals. And I conducted qualitative interviews with 27 staff, nurses, doctors, only 2 microbiologists, and 14 older adult patients. And the patients had been diagnosed with a UTI during that hospital stay. And we recruited from 2 hospitals in the UK Midlands. This was a little while ago, so just before the pandemic. And I conducted a thematic analysis, and the themes that I will be talking about is how clinicians, a bit patients as well, prioritize diagnostic tests, how they prioritize signs as well as symptoms. Could I have the next slide? Okay, so just some kind of quotes from the interviews. And so, in one of the wards, there was new recommendation that you shouldn't be using a dipstick. And the nurses told me that, yeah, they still kept doing that. And so I asked, well, why do you still use the dipstick? Oh, it's nurse training. If it looks off, dip it. See whether it's got any protein or leukocyte. If anything looks like it might be a sign of anything growing. So very much kind of looking, visualizing. And then there is a doctor who is aware of dipsticks being not that good, and saying if the dipstick's positive, then that can be false, which is why you then send a midstream urine, which, would it be too strong to say it's the gold standard? I guess it is. It's telling you if there is an organism that you need to treat. So coming back to Tom's and Annie's talk about the gold standard bacterial culture. And then a patient would say, they must have had a look at my water. I had to give her water. So they tested your water in the hospital. Yes, and they said, I've got a urine infection. So the patient kind of agrees with this idea that you can look at the water and see if there is an infection. Okay, next slide. So observations about this is that this focus is very ocular. It's very looking, seeing. All of a sudden we can see beneath the surface what really is there. Bacteria is imagined in terms of revelation. It becomes visible. It's growing. The organisms, bugs. It's kind of something gross happening in there. And diagnostic tests are imagined as the most reliable. The term gold standard are repeated, especially in the doctors' interviews. Okay, next slide, please. And then about the signs that healthcare professional observes the patient. So nurses were often very keen on this one. They said that nurses are quite switched on to symptoms. So if you get somebody who maybe doesn't drink very much, their urine's concentrated, they complain of dysuria, they have a bit of confusion, it's not really normal for them. It's about picking up on the signs, isn't it? So there are some symptoms and signs such as dysuria, but very much kind of we're looking at them, looking at what they look like. And here's a doctor. With our patient population, I'd be looking for delirium, confusion, a fall off their feet, reduced mobility. We have mainly more dementia patients. Sometimes they can't really accurately describe what's happening to them. So you have to look for the signs rather than ask. So again, we have this sort of looking for the signs, looking at the patient from the outside. And the patients say, how did you end up here? You know, I'm interviewing somebody in the ward. I had giddy turns and falls. I've had 2 or 3 falls. So there again, there is this kind of like something happened, a type of confusion. Next slide, please. And then observations about that. Clinicians were very focused on signs that they could see from the outside. They were looking for them, picking up on the signs. And often these signs were an eclectic mixture. There was some smell, so now I stand corrected. Off their feet, smelly urine, not drinking, confusion, which is the only one mentioned in the guidelines. Okay, and the next one, please. And then the subjective symptoms. Healthcare professionals did kind of talk about that, but not so much. And so here we have a doctor that says, so if the patient was able to tell me a history of urinary tract infections, so, you know, I've got dysuria, my urine's gone funny color or funny smell, then you almost don't need a urine dip because your suspicion is high enough that I would treat. Without them being able to tell me a story, I'll try and get the story from someone else who's very close to them. So here we switch from looking to listening to a story, which is important. And then here we have nurses interestingly enough, didn't talk about talking to patients as much, even though we kind of think that that's what they did. They said if they just seemed a little bit more confused, but their observations were okay, then I would usually say, shall we wait until the test comes back? But some doctors are very quick. If they are not symptomatic, then obviously we just observe and continue to push the fluids. So for nurses, the symptoms or this kind of ambiguity was related to kind of keeping an eye on them, kind of seeing how it develops kind of from the left corner of my eye, rather than immediately saying, yes, there's a confusion. I alerted, the doctor. Then I had quite a few patients who, interestingly enough, said that I know what cystitis is like because I've had 3 or 4, and it wasn't like that. Just smarted a little tiny bit and then it went. So they very clearly said that they didn't think that they had UTI, but they were diagnosed with it anyway, and they were pondering about that. So often older adults were perceived as not knowing what's going on, but they actually often did make quite, astute observations about the situation. Okay, and then the next slide. So basically, when we look at symptoms, there is a shift from vision to hearing, listening to patients' stories. There's also a shift from rapid diagnosis. Okay, let's do it quickly to kind of slow waiting, kind of, looking at how things develop, keeping an eye, taking obs, pushing barley water, etc., kind of living with ambiguity. Patients were actually most focused on this because they're obviously the experts on this, like we heard from Eleanor. They were very focused on whether they felt smarting or stinging. And if they didn't feel that, they felt a bit odded that they were still diagnosed with a UTI. And then the next slide, next slide, please. I'm going to have a little autoethnographic digression, and I have ethical permission for this, if you wonder. Sometimes life imitates science. So when I was doing this study, my 93-year-old mother was diagnosed with a UTI, and I thought that that was funny, and it kind of illustrates the point here. So basically, my mother fainted in Finland and was rushed to the hospital. This was not unusual for her because she's quite old and frail. But, this happened twice. So I was talking to the doctor on the phone, and the doctor said, kind of in a matter of fact, oh, we found this Klebsiella in the urine and gave her IV antibiotics. And I'm like, oh, gosh. But then, several days later, she had not improved. I asked my mom on the phone, you have had a UTI diagnosis, so did you feel anything? And she said, and she was quite angry and frustrated at this point, that she didn't have a UTI and she knew how it feels to have a UTI, and she said that the doctors were rubbish. So she stayed in the hospital for 2 weeks and also had another infection that she caught from there and was actually quite poorly. So I actually made the difficult decision of discharging her against the doctor's instructions, and she came home and, was fine after that. And then a few months later, I interviewed her again and I said, okay, well, remember that UTI? Did you feel anything when you were at the hospital? And she said she had changed her story slightly, said, I felt a bit of a discomfort. But then she said that she definitely didn't need any antibiotics because in the past, she has many times felt a little bit of discomfort and had just put some woolly underpants on and it had disappeared. So here we have the kind of hot water bottle treatment that, lay theory, that she had utilized for many decades. And kind of, illustrates the situation, she's quite frail, what's going on, it's totally unclear, it goes on and on and on. And she also slightly is not clear herself what's going on, even though she does say that she didn't think she had a UTI. Okay, and then final slide, thank you. Okay, so the conclusion here is that I thought that the reason why, I was getting these stories from clinicians that they were diagnosing using dipsticks and bacterial cultures that me being new to this area found quite bewildering is because, there is this very strong modern idea that also matches the idea that the bladder is sterile, right? As Annie said, that microbiological evidence is the best. And the fact that in the case of UTIs in older adults, it shouldn't be used is very counterintuitive. And then the idea that one should observe signs from the outside, again, it is recommended that you look for signs, but, confusion is quite prevalent. It's quite ambiguous for older adults. So that, again, kind of contradicts the idea that the healthcare professionals know best. It's even more complicated with the older adults because we think that they don't really know what's going on. So we better observe, which was contradicted by my interviews with the patients themselves. Not always, but quite often. And then all of a sudden, this sort of an idea that subjective experience of symptoms should be prioritized, pain when urinating, it's difficult for healthcare professionals to kind of turn this hierarchy upside down. So this is very historical. So that's why it's difficult to change. Like Annie said, that I was taught in med school, bladder is sterile. It's stuck me ever since. And then it's complicated by the fact that people usually consider older adults not to know anything. Clinicians said to me, there's no point interviewing them, Paula, because they won't have an idea what's going on. And I said, yeah, well, I kind of like doing patients anyway, so I'm going to go and do that. And they actually were often quite aware what was going on, observing the doctors. And so, it wasn't really fair to consider them as unreliable witnesses of their own experience, which was quite common in hospital. And then the kind of things that, usually led to kind of waiting or let's say diagnosis that was less focused on finding bacteria was paying attention to stories, listening, being able to tolerate ambivalence, having all these practices like pushing liquids, whether they're woolly underpants or whatever, that are kind of less precise and less quick, kind of less modern, almost seemingly kind of pre-modern practices that, were usually associated with, kind of less hasty decision making. And then as I was, coming to the end of my study, there were all these focus on there will be a new precise diagnostic test. So we don't really need to attend to all these woolly factors anyway, which I kind of thought testifies for the power that there will be a kind of precise, clear solution to this problem in the end. But now I'm all riveted that Tom says that actually there is a kind of a halfway house. So that sounds very interesting. So basically, my kind of point here was about, these hierarchies of evidence that is very difficult to break. Matt, could you please fast forward next one? yeah, so just to thank you that I didn't do this alone, but with my colleagues and sponsors and the funder, for whom I am grateful for. Thank you.